Okay, this is lecture 6 of cell pathology and infection, and this is the first of two separate lectures addressing what we call stratified or personalised cancer medicine. So in these two sessions, firstly I'm going to talk about the use of the Oncotype DX assay, which is used to try to predict who is most suitable for chemotherapy and who would not benefit from chemotherapy. And in the second session I'm going to be talking about oncogene targeting therapeutics, so drugs which target growth factor receptor overexpression and targets downstream of growth factors. So this session is going to be on the Oncotype DX assay, and these are the learning outcomes for the session. We'll be really emphasising the understanding of breast cancer subtyping, looking at different ways in which cancer patients can be stratified. And when I talk about how patients can be stratified, you have to think what you already know about how patients are stratified. We know that we can stratify them on the basis of grade, on the basis of stage, some sort of tumour marker. We've covered estrogen receptor positivity in breast cancer in the labs previously. You've covered maybe HER2 expression. I'm going to cover more on HER2 next week. So there are lots of different ways in which a patient can come into clinic and be given a different therapy based upon different features of that individual patient, and that's what we mean by stratified cancer medicine. We're going to be talking about one specific test, which is the Oncotype DX test, which looks at the expression of specific genes and uses those to predict patient survival. And the whole point of doing this is to avoid over-treating patients that don't need certain aggressive therapies. So the idea is that you treat the most aggressive therapies, target the most aggressive therapies to the most high-risk tumours, and those patients who are most likely cured by surgery and radiotherapy maybe do not need chemotherapy at all. So this test that we're going to be studying, the Oncotype DX test, helps to identify the patients who do not need chemotherapy. Now, one thing you should be thinking about throughout this session is what are the current diagnostic procedures to stratify patients, and what is this test actually offering over and above the current diagnostic procedures? Because the current diagnostic procedures are pretty good. You need to be asking the question scientifically, is this new test just doing exactly the same thing, or is it offering something different? So before we get into the test, we're going to look at the clinical situation that this test is used in, and it's used for early stage breast cancers. So if we look at the staging of breast cancers, we have stage 0, where we've got typically a ductal carcinoma in situ, which is the very earliest stage of breast cancer. It's not yet spread beyond the duct, and therapy for that is surgery with or without local radiotherapy. So lumpectomy will be performed there. Stage 1, we're looking at a tumour less than 2 centimetres, which is not yet spread outside of the breast. So surgery and local radiotherapy will be performed most likely with hormone therapy if it's estrogen receptor positive. But the question is, do we add chemotherapy into the mix? And the question you need to know is, well, how many people survive with just this without the chemotherapy, and how much benefit does the chemotherapy add by putting it in? What we often do, a little note there, is that we perform local radiotherapy if a lumpectomy has been performed, because there's a possibility of leaving a small amount of tumour behind if you perform a lumpectomy, and then the local radiotherapy can address any tumour that has been left behind. For stage 2A, again we've got no tumour beyond the breast, but we have got a tumour which is potentially less than 2 centimetres but spread to the very local lymph nodes, or tumour that is 2 to 5 centimetres that has not yet spread to the lymph nodes. So here, do we give surgery, do we give radiotherapy, do we give hormone therapy, do we give chemotherapy? Now, as we'll find out, wherever lymph nodes is involved, you would give systemic treatment. Then we move on to stage 2B, where the tumour is 2 to 5 centimetres and it has spread to the local lymph nodes, or it is greater than 5 centimetres. It's large, it's either spread or got a real propensity to spread. Surgery and hormone therapy are used here, but chemotherapy is used as a matter of course. So whereas in stage 1 and 2A we're really looking at situations where chemotherapy is a possibility but it might not be essential, Beyond that, chemotherapy is always given. So I've mentioned in the previous slide that hormone receptor positivity is tested and hormone therapy is given. And what we're talking about here is estrogen receptor positivity in the tumour as determined by immunohistochemistry. And we can also assess progesterone receptor as well. Now, we've covered this in the PSP2 labs, where you've stained cells for ER or PR. And in this situation, patients are given either tamoxifen or some aromatase inhibitors. And that is a very effective treatment at keeping the cancer from progressing. So even if there's some residual cells elsewhere disseminated throughout the body, those estrogen receptor inhibitors are keeping the cancer at bay. If estrogen receptor is negative or progesterone receptor is negative, we often then test for HER2 status, and if HER2 status is positive, as we'll find out more next week, I've mentioned that in the Oncotype lecture, then the patients are potentially eligible for Herceptin. Now, these cancers are more aggressive than estrogen receptor positive cancers, or you could argue that the estrogen receptor positive cancers are comparatively easily treated because tamoxifen and aromatase inhibitors are so effective. But either way, survival of estrogen receptor negative cancers is lower than that of estrogen receptor positive cancers, and HER2 positive cancers are quite aggressive. If the ER and PR negative and HER2 negative, we term them triple negative, and these are the most aggressive because they have the least therapies available to treat them. Yes, surgery and radiotherapy can be used, but you have to go straight to chemotherapy. You can't use tamoxifen, you can't use Herceptin. Now, just for completeness, and not really relevant for this lecture, but it's there for completeness, so this shows the rest of the stages of breast cancer, which all include chemotherapy, chemotherapy there, chemotherapy there, chemotherapy here. So once we know that the tumour is systemic, then chemotherapy is always given. Whilst ever there is a possibility that the tumour, or the likelihood that the tumour is localised, stage 1, stage 2A, no lymph node involvement, chemotherapy might not be needed and surgery and radiotherapy might be curative. So, we're in the situation where we are studying one specific cohort of these breast cancer patients, women which are estrogen receptor positive, lymph node negative, with stage 1 or 2 disease. Now that's it's quite a good proportion of the breast cancer patients at diagnosis, but it is starting to really stratify these patients. But what we know about these patients is if these patients are treated with surgery, local radiotherapy if it's deemed to be necessary, and hormone therapy, within 10 years 15% of them will have local or distant disease recurrence. 85% of those patients will be disease free at 10 years. So those are patients who are disease free, having had surgery, potentially radiotherapy and hormone therapy, and not receiving chemotherapy. So chemotherapy is not needed for 85% of those patients in this specific cohort. Estrogen receptor positive, lymph node negative, stage 1, 2. The question is, can we identify who are these 15% of patients where disease recurrence occurs? Because these 15% of patients would benefit if we put chemotherapy into the mix. And this is shown here. If all 100 women with estrogen receptor positive, lymph node negative disease are treated with chemotherapy and hormone therapy, what we find is only 4 out of those 100 women would benefit from chemotherapy. So 4 out of the 15 who would have presented with recurrent disease, 4 out of those 15 would be prevented from getting that recurrent disease if they were given chemotherapy. But that means that you've got to treat all 100 people to save 4 people. So in this population group, 85% of patients would be overtreated if we just threw chemotherapy into the mix for all patients. Now, we don't do that, but in this particular clinical trial, that is what was done. 11% might get some benefit but would still relapse. 4% of the estrogen receptor positive lymph node negative patients would benefit from long-term benefit from chemotherapy. The rest of the patients would not. So that is the clinical situation that we're dealing with. And we are looking at a molecular test that can identify who are these 15% of people who might benefit from chemotherapy, to then mean that we only have to treat maybe 15% of the women to get those 4 additional cases out of 100 who would benefit from chemotherapy, rather than treating everybody. And that is the whole point of the Oncotype DX test. So this is the study that actually assessed this problem and developed the Oncotype DX assay. So tumour tissue from over 600 lymph node negative, estrogen receptor positive, tamoxifen treated patients who were all stage 1-2 cases. They were tested for a panel of 21 genes which were known to associate either with a good or a poor prognosis, and tested those tissue samples from a fixed tumour block, tested them by quantitative RT-PCR, so testing gene expression levels in that tumour material for a panel of genes associated with either good or poor prognosis. And these are the genes which have been selected to be tested for. Now, some of these genes you'll be familiar with, some you won't be familiar with. Here are a group of reference genes. These are housekeeping genes: beta-actin, GAPDH, TFRC, that's transferrin receptor. These are just genes which are highly expressed at fairly consistent levels in most tissues. So those are our reference control. Now, the gene groups that are looked at are the HER2 group. So there's a HER2 gene itself, which we know is overexpressed in some aggressive cancers, and GRB7, you don't really need to know what it is, it's just associated with that group. In the estrogen group, you've got the estrogen receptor and the progesterone receptor, and then there's this additional gene here, which don't really concern yourself with that either. Okay, for those who are interested, this SCOOP2 gene is associated with vascular endothelial growth factor receptor activity, and it suppresses tumour growth at high levels. GRB7 here associates us with various tyrosine kinase receptors and helps to promote growth factor signalling. So this is pro-tumour growth, this is anti-tumour growth. On this loosely defined proliferation group, we've got cyclin B1, which you should be aware of. Ki67 you should be aware of. That's a proliferation marker that is routinely used in histology stains. So Ki67 positive cells are proliferative cells. We've got the invasion group. These are enzymes which break down the basement membrane and allow cells to invade and spread around. And then the key one here is BCL2. BCL2 is an anti-apoptotic protein. So if cells overexpress BCL2, then they tend to be resistant to apoptosis. CD68 is a tumour macrophage marker, so the infiltration of tumour macrophages is correlated with prognosis as well. Okay, so the assay works by quantitative RT-PCR, and I know that you've covered this in biomedical investigative techniques. The whole theory of qPCR has been covered, but I'll just give you a very quick reminder that using quantitative PCR, here is our template that we want to analyse. We have a primer here. We have a primer at the other end, which is not shown here. So we amplify DNA and then we allow a probe to bind to it. The probe has got a reporter, the probe has got a quencher. The reporter and the quencher interact with each other, and whilst ever the reporter and the quencher are attached to the probe, they cannot fluoresce, and that's shown down here, because when the probes are not bound to DNA, they tend to fold up like this. Light is used to excite the reporter, so this is what's meant. This is what this little arrow is. That hits the reporter. If the probe is folded up like this, that light is absorbed by the quencher and prevents fluorescence. If the reporter and the quencher are separated from each other, then the reporter can fluoresce. And during PCR amplification, this probe binds to the any newly synthesized bits of DNA and DNA polymerase comes across the probe, cleaves the reporter from the quencher, releases the reporter, and then it can fluoresce. So the reporter levels in quantitative PCR are related to how much PCR product has been generated so far in that reaction. And you should all be familiar with quantitative, with RT-PCR CT graphs such as this, where we follow the reaction from 0 to 40 cycles, we follow the amount of fluorescence given off. This axis is change in fluorescence per cycle, and basically as the reaction progresses, more PCR products formed, more probes bind. As the probes block the path of DNA polymerase, the reporters get cleaved off, and that gives more fluorescence, so fluorescence increases every cycle. And this is a logarithmic scale, this is a linear cycle scale, and then we draw an arbitrary line across and draw a line down, and that is the CT value. That's the first cycle for which fluorescence reached an arbitrary threshold. So this is a CT of 18, this is a CT of 23.5, and that tells us that is related to how much of the transcript was present that we are trying to detect with our specific primers. So in the Oncotype DX assay, we are doing this for all 21 different genes in separate tubes. We're comparing these 16 genes to these 5 reference genes and quantifying how much mRNA is there, because the mRNA is converted to complementary DNA or cDNA, and that cDNA is used in the amplification step. So something with a CT of 18 is more abundant than something with a CT of 23, because the earlier you detect PCR product, the more of it there is. So this slide just shows a selection of the genes, some of the genes that you should actually know about: GAPDH, housekeeping gene, estrogen receptor, HER2, Ki67 and cyclin B1, and it shows the CT values for 2 different patients. Now, what we can do is calculate how much of estrogen receptor there is compared to GAPDH using this calculation here. If you're interested in quantitative PCR, go through this whole process and try and follow it. If you're not, then maybe not. But what you should be aware of is, relative to GAPDH, if there's a lot of a gene that is associated with a good prognosis, that is going to give a good score for the patient and predict a good prognosis. Whereas if there is a high level of something like HER2 and Ki67, then that would suggest that the patient's got a poor prognosis. So I'll just take you through these 2 patients and tell you which one would get chemotherapy. So here's a housekeeping gene. It's 25 in this patient and 26 in this. The amount of RNA determines the CT value of the GAPDH housekeeping gene. In this patient, estrogen receptor is more abundant than GAPDH, whereas in this patient, estrogen receptor is less abundant than GAPDH. Remember, this is an inverse scale. The earlier the CT value, the more of it there is. In patient 1, not only is there a lot of estrogen receptor, there's very, very little HER2, whereas in this one, there's comparatively a lot of HER2. So this is likely to be an estrogen receptor positive cancer. This is likely to be a HER2 positive cancer. This one has got very little Ki67, this has got lots of Ki67, this is proliferative. This has also got lots of cyclin B1, this has got less. So what I can conclude just from these numbers, and I can actually calculate the relative expression exactly using this calculation, but maybe don't worry about that. What I can conclude from this is this patient is probably HER2 positive with a highly proliferative cancer. This patient is ER positive with a less proliferative cancer. So patient 1 might not need chemotherapy, patient 2 definitely does. Now, just extending that concept a little bit more, there's an algorithm that's been worked out as part of this Oncotype DX assay. Basically, we are looking at if you've got a high level for the HER2 group, that is a high level gene expression of the HER2 group, that pushes up what we call the recurrence score. The recurrence score relates to how likely you are to get recurrent disease. So if you've got lots of HER2 and GRB7, that pushes up the recurrence score a long way. That is bad. If you've got a high estrogen receptor group score, that pushes your score downwards, and that is good. The proliferation group pushes the score upwards, that's bad, as does the invasion group, as does the tumour macrophages result. And then don't worry about these two. So what you can see is estrogen receptor good, HER2, proliferation and invasion bad. And we're basically then taking gene expression from each of those groups, putting it into this magical algorithm and coming out with a recurrence score. And you don't need to know how the expression level is actually calculated, because I'm not telling you that. You just need to understand the general concept of it. Anyway, so when you do all of this, you come out with a low score, an intermediate score, or a high score. These are a recurrence score of less than 18 is low. So that is what the patients get at the end of this test. Now what you have to remember, and maybe this slide would have been better early on, is that all of this work is only working on these two groups of patients highlighted in red. So here's your invasive breast cancer stages, stage 1 to 4, ER negative, ER positive. We're only dealing with stage 1 ER positives, stage 2 lymph node negative, ER positive patients. So those are the patients that we're dealing with. Now, most of the patients that we're dealing with will be, you'd expect them all to have high levels of estrogen receptor, because by definition they are estrogen receptor positive. You would also expect them to almost all have very low levels of HER2, because the ER positives tend to be HER2 negatives. So we are dealing with what should be a fairly homogeneous group of patients. And this relatively homogeneous group of patients also have quite a good long-term prognosis. And this is the Kaplan-Meier survival curve for disease recurrence-free survival for patients with a different recurrence score. Remember, the recurrence score is calculated from this, and we can plot how patients do with different scores. So in red are patients who have a high recurrence score, so they tend to be patients who have HER2 expression in their tumours, probably lower estrogen or progesterone levels in their tumours, high level of the proliferation markers in their tumours. So those are coming up with a high recurrence score with a poorer survival. Whereas these patients are in green are patients with a very low score. Now the blue line here represents 15%. Remember, 15% of these patient cohort will have some sort of distant recurrence within 15 years. Sorry, within 10 years. So at 10 years, basically the patients in the intermediate risk sort of represent the average for the whole group. But what it highlights is all of these patients who are green with a low recurrence score probably do not need chemotherapy, whereas the patients in red are the patients who probably do need chemotherapy. So this Kaplan-Meier survival curve shows what happens if you do another clinical trial. This is another big clinical trial here. And when you randomize patients into tamoxifen alone or tamoxifen plus chemotherapy. So for the whole breast cancer stage 1-2 lymph node negative ER positive population, if you give tamoxifen versus chemotherapy, you get a significant increase in survival, but it represents about 4% benefit. That's by giving chemotherapy to everybody. You get a 4% benefit. If you give chemotherapy to the low recurrence score patients, you get no benefit at all. If you give chemotherapy to the intermediate recurrence score patients, you might get a benefit at 12 years, but at 10 years there's no difference. If you give chemotherapy to the high recurrence score patients, you get a 28% absolute benefit in the proportion of distant recurrence-free survival. So you can clearly see that if anybody is going to get chemotherapy, it should be this group, but the low recurrence score patients are being overtreated and they are getting zero benefit whatsoever. Now these next graphs just show the same data but in slightly different ways. It shows the split of patients, so about half of the patients are low risk about a quarter high risk, about a quarter intermediate risk. So 51% of the patients are in that low risk group. Now the 10-year rate of distant recurrence is only 6.8% for those low risk patients, whereas it's 30% for the high risk patients. So we can direct chemotherapy to these patients and avoid over half the patients from receiving chemotherapy purely on the basis of this simple molecular biology test. And this graph here represents all of the possible recurrence scores from 0 to 50 and showing the likely frequency of rate of distant recurrence at 10 years. So the low group, if you get a recurrence score of 18, you've got a 10% chance of distant recurrence within 10 years. So all of those patients with a less than 18 recurrence score would be the ones where you would avoid chemotherapy, whereas everybody over 32 would be definitely given chemotherapy. Those in the middle, we're not sure if chemotherapy benefits them or not. And this is the same sort of data in a different way, showing the absolute increase in distant recurrence-free survival at 10 years, showing that the low and the intermediate groups have no absolute benefit at 10 years, whereas the high recurrence score group have a really significant survival benefit at 10 years if their chemotherapy is given compared to patients where chemotherapy is not given. So the key points of this test is that the Oncotype DX test, using the recurrence score, it quantifies the risk of recurrence of women with lymph node negative estrogen receptor breast cancer. Patients with a low recurrence score have minimal, if any, benefit. I would say no benefit whatsoever, while patients with a high recurrence score have a significant benefit of chemotherapy, and that means you can divert chemotherapy to those patients that need it. Most crucially, you don't overtreat over half of this patient group. Now this test is not currently all that widely used. It's used by some private clinics to test patients, especially under insurance, medical insurance. If a patient is going to either have chemotherapy or not, some of those insurance companies are using the Oncotype DX test to find out whether it is worth the patient having that chemotherapy or not. It is NICE approved, but not many health authorities are currently using it. The price of it is several £1000s, so it's likely to be financially beneficial if you are making sure that over 70% of your patient cohort doesn't need chemotherapy. So on that basis it seems quite positive. So the question is, why wouldn't health authorities use this routinely if it offers good value for money? If we can avoid 70% of patients from getting unnecessary chemotherapy, then surely that is good value for money if the test is only a few £1,000s. And the reason why is because we already do what the test is doing. We already use a combination of grade and stage to predict who is going to likely relapse and who is not. Now, I've talked a lot about the Nottingham grade. There's also the Nottingham Prognostic Index, and this calculation takes into account the size of the tumour multiplied by 0.2, add that to lymph node positivity status, and add that to the grade from the Nottingham grade, and that's the sort of the sum grade, and then you end up with a Nottingham Prognostic Index. So if we're dealing with a patient who's got a 1 centimetre tumour, well, 1 times 0.2 is 0.2. If it's lymph node negative, well, it's adding on 0, and if it is a grade 1, so low grade, you add on 1, so that will be a score of 1.2. On this Nottingham Prognostic Index, a score of less than 2.4 gives a very, very good prognosis, 96% 10-year survival. Now, so this can be used by clinicians and pathologists to stratify patients based on tumour grade, tumour stage. You can also do immunostaining of Ki-67 staining. You can also look at the degree of estrogen receptor positivity, and we can use a combination of those things to stratify patients onto chemotherapy versus non-chemotherapy. Whereas all of the data I've just shown you is trying to stratify patients without doing any of this, apart from having its stage 1 and 2A, and apart from being estrogen receptor positive, they're not taking into account grade. They're just saying, irrespective of grade, we can do this test. Now, it may well be that the patients that the Oncotype DX test identifies being low risk are the same as the ones who've got a low Nottingham Prognostic Index, but as far as I know, that has not been done. So the question is, are the Nottingham Prognostic Index and the Oncotype DX just identifying the same low risk patients? And it's quite likely that that is the case in most situations. The Nottingham Prognostic Index and the Oncotype DX might be pulling out the same people, which then makes the cost of the test really not as appealing, shall we say. So what I want you to do is go through these next 3 cases, calculate the Nottingham Prognostic Index and compare it to the Oncotype DX score, and see if you think that those patients are whether this Oncotype DX test and Nottingham Prognostic Index is just identifying the same patients for chemotherapy. So here's the first patient. Patient 1.5 centimeter tumour, so that's useful in your Nottingham Prognostic Index. It's grade 2, that goes into your Nottingham Prognostic Index, and the lymph nodes are negative. So you can calculate a Nottingham Prognostic Index from that. Okay, and then you can also look at the recurrence score from this patient who had an Oncotype DX test, and that patient came out with a recurrence score of 4. This patient is very unlikely to have a recurrence. So far so good, because by my calculations 1.5 times 0.2 is not very much. Add that on to grade 2, you get something that is less than 2.4. So this person should come out with a Nottingham Prognostic Index of the less than 2.4, and they should have a very good survival. So the Oncotype DX test has done exactly the same prediction as the Nottingham Prognostic Index. So for the next patients, I'll let you do the maths and you figure out what's going on. But here we've got a 1.3 centimeter tumour. It's a grade 3 lymph node negative. Well, it would be. All of these are going to be lymph node negative. And the recurrence score is high. Another patient, 2.3 centimeter tumour. It's grade 2. Lymph node obviously negative. And the recurrence score is somewhere in the middle. Now this patient with an intermediate recurrence score of 25, you can calculate the Nottingham Prognostic Index yourself, but what I've flagged up here is there's been a subsequent trial to assess the benefit of chemotherapy in these intermediate patients that have an intermediate recurrence score, and that is shown on the last slide on the PowerPoint. This is just shown here, and this was the TAILOR-X trial, and it looked at women who were under 50 versus over 50, and the conclusions of this huge trial was that the under 50s possibly benefited from chemotherapy if they had an intermediate recurrence score, but the over 50s didn't. So that indeterminate region here is being further stratified by a follow-up study. So what I want you to think about then, and we've sort of worked through this, but the question is, how does Oncotype DX compare to current methods? Now, the way the test was first sold to me when I first saw it was this test can predict patients independently of grade and stage. And I thought, oh, that sounds clever. But then I thought, well, why would you want to do that if you're doing all of this work anyway? So what I want you to do is go back through those 3 patients, write down brief notes on each patient, and write down what you think the benefit of the Oncotype DX test is adding. And we can discuss what we think about this test in the extra tutorial that I'm putting on Thursday afternoon in week 19. Okay, that's the end of this session.